Despite this much importance, LDL remains grossly overlooked and underestimated, no matter how much studies have been there. Mendelian randomization studies are you take a population who have certain genetic defects which are associated with extremely high LDL, and they are exposed to extremely high LDL right from birth, as opposed to garden variety of dyslipidemia where modern lifestyle causes high LDL, and that happens in second and third decade. As opposed to that, there are Mendelian genetic defects where your LDL remains extremely low in 10s and 20s right from birth. So in those studies, it has been clearly demonstrated this log-linear relationship between LDL concentration and ASCVD. And Eugene Braunwald, the doyen of cardiology, he says that if you want to live up to 100 without CAD, keep your LDL lifetime below 100. American Pediatric Association recommends that even at your diet can start at the age of 2, and statin therapy can start at the age of 8 if the patient has a familial hypercholesterolemia.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your like video so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Let's jump directly to the topic. Can I have the first slide, please? Well, friends, so far as chronic lifestyle related diseases are concerned, we have been seeing a downward trend in our targets, whether it is blood pressure, wherein we started from essential blood pressure, did not be treated even at 200 or 250, which happened with Franklin Roosevelt maybe around half a decade ago. And then we went down to 160, then 150, then 140, and nowadays we are talking about 130. But it seems that at least in blood pressure, we have reached the bottom. Similar things happened in patients with diabetes, A1C control from 8 to 7.5 to 7. And now, with more and more medications available which do not cause hypoglycemia, probably we feel that 6.5 might be a better target. But there again, we have reached the bottom. So, do we have such bottom in LDL in dyslipidemia? Well, the concepts are fast changing, a lot of data is accumulating, and a lot of expert opinions are forming. And in today's talk, in next half an hour, I'm going to dwell upon the extremely low LDL. What are the pros and cons of it? So, Sarika, can I have the first poll, please? Can we have the first poll just to know the audience reaction? Well, friends, do you use high intensity statins routinely in all diabetic patients above the age of 40? By high intensity statin, I mean rosuvastatin 20 or 40 and atorvastatin 40 and 80 in all patients with diabetes or ACS. Please vote now quickly. This is just to know what are the general perceptions. Well, friends, there lies the gap in the guidelines versus the real practice. 56% of the audience believes that high intensity statin is routinely recommended in every diabetic patient above the age of 40 and every acute coronary syndrome patients. So, with that knowledge about what is the perception of the population, let's move forward. LDL is extremely crucial and the causative agent. Couple of decades back, we just had an association between dyslipidemia and ASCVD and atherosclerosis, association between hypertension, obesity, etc. But we are not sure about the causative agent. And over the decades, the knowledge has changed based on the genetic Mendelian experimentations, the experimental data, molecular biology, histopathology, epidemiological data collection from people with high coronary artery disease, low coronary artery disease, populations who already presented with clinical ASCVD, and clinical data in terms of trials, LDL reduction trials, etc. We once believed that it is necessary and sufficient cause for ASCVD. Necessary means if you do not have uh, if you do not have LDL in your blood, you are not going to develop atherosclerosis, no matter what other risk factors are there. And it is sufficient. Sufficient means if LDL is sufficiently elevated, say 200, 250, 300, then no matter whether you have any other risk factors or not, you are going to develop ASCVD. Well, by and large, this statement is true, but it's not the whole truth. Of course, we do not have any kind of models where the patient's blood LDL levels are zero. But by and large, this is truth, but not the whole truth. What I want to say by this is the LDL should be the most important focus when ASCVD prevention and treatment is concerned. And despite this much importance, LDL remains grossly overlooked and underestimated, no matter how much studies have been there. Conventionally, low LDL is, there is a little typo here. Low LDL is what we call below 70. Very low LDL would be something like below 50, and ultra low LDL will be something like below 20. This is not a classical definition defined by any association, etc. But this is something what we commonly talk of in academic circles. So let's see what's the association between LDL and atherosclerosis. The epidemiological studies have consistently demonstrated that there is a dose dependent and a log linear relationship between plasma LDL concentration and risk of ASCVD. So, as the LDL keeps on rising, your risk of ASCVD keeps on rising proportionally in log linear relationship. Conversely, as it keeps on dropping, the risk of ASCVD keeps on dropping. It is replicated in Mendelian randomization studies. Mendelian randomization studies are you take a population who have certain genetic defects which are associated with extremely high LDL, and they are exposed to extremely high LDL right from birth, as opposed to garden variety of dyslipidemia where modern lifestyle causes high LDL, and that happens in second and third decade. As opposed to that, there are Mendelian genetic defects where your LDL remains extremely low in 10s and 20s right from birth. So, in those studies, it has been clearly demonstrated this log linear relationship between LDL concentration and ASCVD. One thing needs to be noted that diet and lifestyle constitute to a very low percentage, not more than 10 or 15%. But despite that, both diet and exercise are a significant and vital contribution to lipid levels and atherosclerosis. So it remains a common advice everywhere, but one cannot solely rely on diet and lifestyle to reduce your LDL beyond 10 or 15%. It has been shown consistently across multiple trials, millions of patients being analyzed, that every 1 millimole, which in our terminology, because we measure it in milligram per deciliter, 1 millimole is 39 milligram per deciliter. Every 39 milligram per deciliter reduction in LDL confers a 22% reduction in the risk of major adverse cardiovascular events. So, roughly 2 milligram per deciliter LDL reduction will give rise to a relative risk reduction of 1% in ASCVD. Now, the important part is that the lower threshold beyond which this benefit ceases to exist is not yet defined. Previously, our targets were 130. Then the current European target in low risk patients is 116. Then we went down to 100. Then we said that no, ASCVD and diabetic patients and all patients with familial hyperlipidemia need to have a target LDL of less than 70. And then the European guidelines came that, for a secondary prevention, ASCVD patients target should be 55. And on top of that, certain high risk secondary prevention cases, you can go down to 40. Now, where did this data come from? There were no specific trials targeting 55 or 40. For 70, Yes, we did have trials where certain subgroup of patients having LDL more than 70, they were put on high intensity dyslipidemia therapy. But 55 and 40, we do not have data. And so far as this data are concerned, they are mainly Western data, European data, or American data, or Australian, Canadian data. In India, we do not have those strong data. But fortunately, Lipid Association of India has surveyed all of the literature, and on similar basis, post hoc analysis, subgroup analysis, and expert opinion based, they have come out with guidelines specific to India, and which I believe are one of the strongest guidelines for Indian patients. We are going to look at it in few of the later slides. So, what we are trying to achieve with intensive LDL lowering, we want the plaque to stabilize so that the clinical events are prevented. Acute coronary syndrome, strokes, and consequent heart failure, need for revascularization, and death comes down. We need to halt the plaque progression. Both these aims have been largely achieved with the current guidelines of less than 70, less than 55, less than 40. But to induce regression, we need something more. If you want to have a very clinically meaningful regression, probably you need to go down still lower. Unfortunately, the proof is far away. We do believe that extremely low LDL would help in at least early and mid stage plaque regression. Risk stratification is extremely important. The risk can be divided into primordial risk, wherein you prevent the development of risk factors. You prevent hypertension, you prevent diabetes, you prevent obesity, you prevent smoking. That is primordial prevention. Primary prevention is in patients with risk factor. You prevent the patients from going to the clinical ASCVD. That is primary prevention. In the primary prevention, there are many risk categories based on the epidemiological data. We have risk calculators available. We are going to discuss that shortly. And then comes the secondary prevention. Hitherto, we were thinking that secondary prevention is the patients who already has developed an clinical ASCVD event, infarct or stroke. He already is a high risk candidate. But now we know that among the high risk, also there are various gradations of risks involved, and those gradation of risks would ultimately dictate how intensively we would be reducing LDL, how how much cost we are ready to accept for that intensive reduction, cost in terms of the expenses, the money, and also the cost in terms of side effects. So we need to compare the net clinical benefit, the clinical benefit or reduction in ASCVD versus whatever side effects, and you do the balancing between the two. And if you have a gross net clinical benefit, then even extreme low levels are justified even at the expense of some cost or some consequences. So recurrent cardiovascular event is one such extreme risk category. We are going to see the in detail about what Lipid Association of India tells about. Now, how do you estimate the risk? Baseline risk assessment is the foundation of all preventive cardiology. You need to know what is the patient's baseline risk. If the patient's baseline risk is say 5%, very low over 10 years, then even a 20% risk reduction would generate into just one patient's event being prevented at the cost of 100 patients being treated. But if the patient's baseline risk is say 40%, a 20% relative risk reduction in that group of people would lead to 10 ASCVD events being prevented for 100 treated, which will translate it to number needed to prevent one ASCVD event would drop down to say 10, and that would be a very big uh, advantage to the patients. You are not treating too many patients, but you are still gaining a huge amount of clinical benefit. Guidelines recommended defining LDL treatment thresholds based on the patient's risk. A low risk patient has a different threshold, intermediate risk has a different threshold, high risk patient has a different threshold. There are many risk calculators available. In general, they do all have limitations. Till we have a perfect risk calculators available, which I feel in the next years to come, AI is going to give us that risk estimation in a better way. Short of that, before the AI gets trained and we get trained into AI, how do we classify and what are the limitations? It's better to understand. Uh, Largely, the risk calculators are based on the representation of certain racial groups. Like Framingham risk score was based on American people who were staying in Framingham. Similarly, we have European data which are focused on Europe, and even Europe being such a wide region, different regions of Europe have their own different risk calculator factored in. They focus solely on traditional risk factors like hypertension, diabetes, smoking, LDL levels, family history, etc. And some calculators even do not factor into all the traditional risk factors. While these risk factors, they overestimate the risk in East Asian patients, but we South Asian patients it underestimates. So the pooled cohort ASCOD risk calculator, which is one of the most popular risk calculator used, if we put our Indian patients data or if we put our own data, if we get say a risk 10-year risk of 15% for for an Asian patient, it needs to be multiplied by 2. So if the risk calculator gives you on a South Asian patient's data a risk of 15%, the actual risk for you is 30%. So these are the gross underestimation of risk in South Asian patients. It overestimates the risk in people with a higher socioeconomic status, underestimates in people with disadvantaged socially background, and risk calculators also they are not applicable to people with familial hypercholesteremia because they are already in extreme risk category, their LDL being more than 190 right from birth. And beyond traditional risk factors, there are many other risk factors and markers are known to us, like lipoprotein A or LP-little-a, chronic kidney disease, chronic inflammatory conditions like rheumatoid arthritis, SLE, etc., family history of premature ASCVD, polygenic risk scores after genetic analysis, multiple small genes contributing slightly to the cardiovascular risk, history of premature menopause, subclinical atherosclerosis, even earlobe crease, premature arcus senilis, erectile dysfunction, mental health issues, environmental pollution, hyperuricemia, HIV, uh, etc., have been found to be contributed to the risk. How many of them are really independently affecting or acting via one of the pathways of dyslipidemia or inflammation? We are not sure. Time will tell. But these are few of the pointers or facts which you need to keep in mind. So when you do a risk calculation, other parameters which are likely to affect the risk, you may as well jot down there and take your final decision whether to put that patient on statins or not, and if on statin, whether moderate intensity or high intensity. They can help you decide in a patient whose risk falls onto the border zone where you are not very sure what to do. Uh, the few of the risk factors available are ASCVD risk estimator, which is a pooled cohort data. Prevent risk estimator is a new one which promises to keep on updating the risk parameters based on ongoing data. Score risk 2 and 3 are the European risk calculators. There is also score risk diabetes for specifically meant for diabetic population. QRIS 3 is based in UK. Fortunately, some of those data collection they involved Indian, Pakistani, or South Asian patients. So probably that might be more applicable to us. And there is a QRisk lifetime risk calculator available. You just search for them online. Free risk calculators are available. You put various parameters into the risk, and you will get the patient's 10-year or lifetime risk as the case may be. Majority of risk calculators start calculating the risk at the age of 40 because they collected the data from 40. By and large, ASCVD started at the age of 60, 65 in Western countries. So they started looking at from 40. But now we believe that even in your teens, what you calculate might tell you what is you are going to be a future risk. And that is probably the time when your best risk prevention should start, because there is something like lifetime exposure to LDL. We are going to see that in one of the future slides. Now, This is the ASCVD risk calculator. Below the age of 90, you don't have any risk calculator, but if you are diagnosed with familial hypercholesterolemia, you might start statin therapy down up to the age of 8. American Pediatric Association recommends that even at your diet can start at the age of 2, and statin therapy can start at the age of 8 if the patient has a familial hypercholesterolemia. And if you have a family history of premature ASCVD, LDL is more than 160, then even between 20 to 40, after taking the patient's views in consideration, you might consider starting statin therapy. If the LDL is between 70 to 190, above 190, they would fall into familial hypercholesterolemia, strong suspicion. Between 70 to 190, 10-year ASCVD risk can be defined. If it is low, less than 5%, these are few of the, you just recommend them healthy lifestyle. Between 5 and 77.5% 10-year risk, it's known as borderline. You discuss the lifestyle modification and probable statin therapy, which will not be high intensity, it could be moderate intensity. Between 7.5 to 20%, it is intermediate. Statin therapy by and large would be recommended, and moderate intensity statin therapy. Moderate intensity statin defined as statins which reduce your LDL by 30 to 50%, which happens with 20 to 40 milligram of 10 or 20 milligram of atorvastatin or 5 or 10 milligram of rosuvastatin. If your risk is falling in high category more than 20, high intensity statins are recommended where LDL fall is more than 50%, and that happens only with Rosua 20 and 40 and Atorva 40 and 80. Some of the patients, even those dosages may not be enough to achieve your goals, and you might need to add either oral or parenteral non-statin therapy. Again, I would like to emphasize, if you are using ASCVD risk calculator for our Indian patients, whichever risk value you get, you have to multiply it by 2 to be applicable to our Indian patients. Now, where did the data of ultra low LDL came from? Whenever we tried to do in patients above 70, a combination therapy was tried in IMPROVE-IT. Statin plus ezetimibe was given, and almost 6% of the patients in the process achieved an LDL of below 30. And in this group of patients, subgroup analysis, of course, this was not the primary endpoint of the trial, but it was found that there was an additional meaningful clinical benefit in terms of ASCVD reduction, and there was no additional side effect of those ultra low LDL therapy. And then, of course, multiple trials came. Even in secondary prevention, as I have told you, we need to risk stratify the patient. And even if you give high intensity statin in secondary prevention, there is a significant residual risk. Majority of that risk is by LDL, but part is because of triglyceride, which contributes to non-HDL lipid levels. It residual risk is also comes from inflammation, another major pillar in the pathophysiology of atherosclerosis, and of course your thrombotic risk. Lp(a) has both dyslipidemia as well as thrombotic risk because of its structural similarity to plasmin. Now, these are the trials of high intensity statin when we are trying to see whether achieving LDL below 70 is going to be helpful. Those days, 100 LDL was the gold standard, the gold post for us. But then there was a significant residual risk. So these are very well-known trials. PROVE-IT, TIMI22, IDEAL and TNT trial. They all tried to achieve LDL below 70 from people whose LDLs were above 70. Their baseline LDLs were around 100. On treatment, average LDL was around 70. You can see here from 62 to 80. And despite achieving below 70 target, what is the residual risk? In the treatment group, the absolute risk was 22% in PROVE-IT. So 10 to 20% residual risk was there, which is a phenomenal risk in patients needing secondary prevention despite achieving LDL below 70. This formed the basis for subsequent higher and higher intensity LDL reduction. And if you can analyze the data, people who achieved who could not achieve LDL reduction, they remained above 175. If you consider their risk as 1, progressively, as you come down to 150, 125, 100, 75, 50, or less than 50 LDL, there was a significant reduction. Here, if you count as unity, here the risk reduction is 29%, 36%, 42%, 44%, 49%, and 56% risk reduction if you achieve LDL less than 50. Though this was not the primary endpoint, but based on this, the experts decided there is no point in doing a specific trial targeting less than 50, go down. And even in patients where LDL was achieved below 50, there were no significant additional consequences of concern. This slide is based on the score risk, and here it says that people who are at high risk, you go to less than 70. Who are the high risk patients? Patients with a score risk between 5 to 10%. Score risk is a mortality risk. It's not just clinical ASCVD. It does not account for infarcts and strokes. Only fatal cardiovascular events it takes into account. So 5 and 10% becomes a very significant high risk. So if you have CKD, if you have a diabetes more than 10 years duration, familial hypercholesterolemia, or markedly elevated single factor, like your total cholesterol more than 300, LDL more than 190, blood pressure more than 180 by 110. This defines as a high risk people, your LDL should be less than 70. And very high risk people are people with ASCVD, clinical ASCVD. Not only clinical ASCVD, if you just happen to do a CT coronary angio or a carotid ultrasound scan, and if you find a plaque, femoral ultrasound, and if you find a plaque, you already fall into secondary risk category and your LDL target is less than 55. And of course, if you have selected patients who have a recurrent ASCVD events, they fall into a high risk category and your target is less than 40. Again, this was not based on trial, but based on understanding and post hoc analysis and subgroup analysis of previous existing trials. Now, is it important? Because statins, when statins were ruling the world of dyslipidemia therapy and other therapies were not there, we were all gung ho about the non-lipid benefits of statins like HSCRP reduction and insulin sensitivity, and there are dozens of other off-target effects of statins were described. But now that myth has been cleared, when baseline mean LDL was something like 70, on top of 70, if you reduce LDL by 38, you whether you use statin, you have a 22% reduction. Non-statin, you add to statin, you have a 21-22% reduction. And irrespective of what you use, you have something like 21% reduction. So irrespective of by what agent, by what methodology you reduce LDL, the proportionate reduction in risk is similar. Statins do not have any very special advantage over and above other dyslipidemia therapy other than what it can do in terms of LDL reduction. Now, diabetic patients were found to have better benefits. FOURIER trial, ODYSSEY trial, IMPROVE-IT trials. Non-diabetic patient absolute risk reduction was 1.6, 1.2 or 0.6 over here, and number needed to treat 62, 83 or 166 to prevent one event. So if you treat this many number of patients like 60 to 160, you prevent one event. But in diabetics, the absolute risk reduction comes to 2.7, 2.3, 5.5. Why is that? The proportionate reduction is same, but since the diabetic patient's absolute risk is higher, their absolute risk reduction also is higher. In non-diabetic also, if you have a 50% risk reduction, and diabetic also you have a 50% risk reduction, but non-diabetic your baseline absolute risk is 20%, then the relative risk reduction by 50% will give rise to a benefit of 10. While in a diabetic patient, if their absolute risk is 40, a 50% reduction will give rise to a 20 events being prevented. That is what this is shown by. But that also tells you that you must focus on diabetic patients and never miss an opportunity for targeting their LDL to respective recommended levels. Again, in secondary prevention, whether you had a multivessel disease or no multivessel disease, the risk reduction, absolute risk was higher in people with multivessel disease. They benefited more, and that is the basis by which we say that the extreme risk secondary prevention patients, you reduce down LDL from 55 to 40, 40 to 30. If you had a myocardial infarction less than 2 years, recent infarction increases the risk versus people who had more than 2 years and they had a stability of 2 years. And people who had a multiple myocardial infarction, their risks were on higher side. So these are very high risk features in secondary prevention category of patients. That's something which we need to understand. Now let us come to the real extreme low risk patients. Extreme low LDL. These are the trial on PCSK9. With placebo and high intensity statin therapy, the median LDL achieved was something like 90. When you gave PCSK9, there was on an average 59% reduction, and the median LDL achieved was 30 milligram. This is something like extremely low levels. But not everyone achieved this 30 milligram. In the bottom right square, if you see, the x-axis shows that achieved LDL levels. Some patients on the right side, you can show 4 millimole, which is equivalent to almost 150 milligram per deciliter. And some patients on the left side of the x-axis achieved 0.5. 0.5 is 20 milligram and even below. So people achieved less than 10. Now come to the left top corner. On Evolocumab, on PCSK9, 87% achieved their LDL of less than 70. And if you say less than 25 milligram LDL achievement, 42% achieved less than 25. These are extreme low categories. As compared to placebo, hardly anyone reached below 70. Below 70, only 18% reached, and below 40, less than 0.5%. So on PCSK9, more than 40-45% achieved their LDL below 25. And now you focus on the left lower block, and you can see on bottom that if your LDL was 70 to 99, your relative risk reduction was 3%. And progressively, if you go up from 70 to 99, if it goes to less than 20, you have a 24% risk reduction. Less than 10, you have 31% risk reduction. So it clearly proves that extremely low LDL, even in single digits, LDL less than 10, there is a clear, perceptible, statistically significant improvement in cardiovascular outcomes. This was the data, and in this group of patients, what were the incidence of adverse effects? Hardly any. We have a lot of post hoc analysis and data available where the risk is not very high. This forms the basis that an occasional patient where you put them on statin plus estimab or statin plus bempedoic acid and his LDL drops down to say 15 or 20 or 25, if he does not have any side effect like muscle pains, etc., there is no need to be scared about, no need to de-escalate the therapy, particularly if the patient was diabetic or he already had an ASCVD. This is something which is to be kept in mind, because every month I get one or two patients whose LDL drops down to say something like 20, 25, and the pathologist informs the patients that your cholesterol is extremely low, contact your cardiologist and urgently, right now you call him up. No, it's not needed. That's quite safe. In fact, it's probably going to be helpful. Now, this is an important slide. The Lipid Association of India's recommendation. Since we do not have specific Indian data, they have not devised a calculator. They have gone on old method of counting how many number of risk factors you have. So major ASCVD risk factors, left upper corner, age more than 45 in male and 55 in female. Here they have taken age of 45. In Western countries, they take age above 55. But in India, on an average, we get all cardiovascular disease 10 years younger. So age as a risk factor is counted more than 45. Smoking, tobacco, high BP, HDL cholesterol. There are other high risk features like AS, family history of premature coronary artery disease, CKD, apolipoprotein, ApoB more than 130. So lots of factors, even calcium score has been factored into metabolic syndrome is factored into, LP little a has been factored into, alcohol has been factored into, and then there are risk modifiers on right upper corner. Combine all those together, you can put the patient in low risk, moderate risk, or high risk groups. And these are the groups where you'll have your specific LDL targets. Our focus is in very high risk group. Which are they? Diabetic patients with end organ damage, diabetes, and plus more than 2 ASCVD risk factor, calcium score between 100 to 300, more than 2 uh, high risk features. So high risk features on the middle side, if any of the 2 high risk features are there, patient would fall into a very high risk group. So this is a kind of chart which is not easy to remember. It's better to print and keep it on your table or onto the wall where you're practicing, and maybe keep one copy into any patients who needs risk stratification. Just tick your points and calculate them. Then they have come out with the extreme risk category. This is very unique to Indian guidelines. Category extreme risk category A, ASCVD with more than one feature of the high risk group, calcium score more than 300, and homozygous familial hypercholesterolemia. Here your target LDL is 50, optional target is 30. Category B would be ASCVD with more than one feature of very high risk group, uh, polyvascular disease. So somebody who had a stroke and infarct, or infarct and peripheral vascular disease, they would fall into polyvascular group. And of course, homozygous familial hypercholesterolemia, they fall into extreme category B, where your mandatory target is 30 LDL. And recently in 2023, they have come out with extreme risk category C, that is the patients who have already achieved their LDL of 30, and despite that, if they get a cardiovascular event, then even 30 is high for them, and drop it down to 15 or 20. That is the kind of aggressiveness with which we go in our Indian guidelines. It's highly needed, looking at double the risk of ASCVD in India occurring in a younger population, on an average 10 years younger. This slide we have already discussed about how much LDL targets at various risk category levels. Extreme risk category A 50, optional target 30. Category B, your mandatory target is 30. And category C, which is recently defined, your targets are 15 to 20, additional 15 to 20 reduction. You use various modalities to reduce your LDL. Healthy lifestyle, well-proven lipid-lowering treatments like statin, ezetimibe, bempedoic acid, or PCSK9 inhibitors, or siRNA technology, inclisiran, or newer drug treatments. You modify your treatment intensity based on risk category, based on patient's baseline LDL, because your baseline LDL will tell you how much intensity you will be needing. Suppose somebody comes LDL of 100, target is 30. Statins alone are not going to be enough. At the most, they'll give you 50-55% reduction. PCSK9 alone will not be enough, because at best it can give you 60% reduction. Still, you are not going to reach 30. So in this group of patients, upfront dual or triple combination therapy may be justified. What about elderly people? Even frail elderly people, they tolerate statins well, but because of the muscle side effects, etc., you might think of, in non-emergent situations, of starting with moderate intensity statin therapy, or give a combination of statin plus non-statin therapy, because non-statin therapy, by and large, they do not have that much of muscle symptoms. And net clinical benefit, even in elderly people, is clearly proven. So there is no need to deny them this just because they have become elderly, they are at the far end of life. In acute coronary syndrome, there is enough of evidence to show that there is a concentration of risk in early few days, weeks, and months, and there is urgency to reduce LDL to very low levels. Now, rapid and variable level reduction occurs only with injectable PCSK9 therapy. Everybody cannot afford PCSK9 therapy. So there are a lot of thinking going on upfront dual therapy. You start with rosuvastatin 40 plus ezetimibe 10, or rosuvastatin 40 plus bempedoic acid 180. And there is also a talk of upfront triple therapy, rosuvastatin, ezetimibe, and bempedoic acid. None of them are proven, but but based on the understanding of trials and data, it is worthwhile at least for a couple of months treat them with this triple therapy, or at least very high risk ACS affording patients covered by Mediclaim or corporate insurance policy, etc. Think of giving PCSK9 inhibitors at least for a couple of months. Now, so far we are talking about how low to go. It is equally important to know that how long to remain low. Now, somebody has calculated that lifetime exposure to LDL above 7 gram. So you calculate your LDL levels, multiply by age. So overall lifetime exposure 7 gram is a threshold where you are likely to develop ASCVD. The green line says our routine usual patients whose LDLs are say 100, 110, 120, 130, and by the age of around 65, 70, they reach the clinical the threshold of 7 gram exposure and they get ASCVD. At an earlier stage, if you risk stratify them and identify high risk patients, give them on high intensity lipid lowering therapy, their trajectory lowers down and maybe up to 100 they are not likely to develop. As opposed to that, uh, certain genetic abnormalities, certain alleles where familial hypercholesterolemia is there, your LDL receptors on liver are absent or defective, your LDL right from birth are 190 or 200 or 230. These are the patients by the age of 18 or 20, they're likely to develop ASCVD. And this is the paper by none other than Eugene Braunwald, the doyen of cardiology. He says that if you want to live up to 100 without CAD, keep your LDL lifetime below 100. So, by the age of 60, if you find out that your LDL was 150, 160, and now you start to reduce, you are not going to get that much benefit. And if you want to get benefited, your LDL targets will not be then 100, it will go down to 50s and 60s and 30s like that. So, this is conceptual. There is no actual clinical proof for that, but lifetime exposure to LDL, the lower you achieve and longer you achieve and earlier you start, the more benefit you are likely to have. What are the modalities available we have for these things? For reducing LDL to extreme low levels in 20s and 30s, we have PCSK9 inhibitors, evolocumab, alirocumab, and small interfering RNA therapy, inclisiran. These are clinically available. But believe me, friends, sometimes even with statin plus ezetimibe in occasional patients, because individual variations are there, you do get 20s and 30s LDL. So keep looking for it, and if you achieve that, celebrate it, don't get scared. There are many things on the pipeline. Oral PCSK9 inhibitors. Here you have, these are all injectable therapies. You have oral PCSK9 inhibitors, oral antisense and oligonucleotides, CRISPR gene editing therapies, and vaccines. Vaccines have a potential of 100% compliance because once it is injected, poof, for lifetime, that patient's LDL metabolism is so affected that LDL would remain on the lower side. That is something which is in phase 1 or preclinical trials. Maybe it will take a decade or more before we see it. So what could be your approach? Coming to last few slides, for LDL management, identify patients at higher risk of ASCVD events, whether they are in primary or even secondary prevention. Recognize the lipid lowering therapy targets. Monotherapy or combinations are grossly underutilized, and you should be looking for the non-responders or under-responders or non-achievement of target. Overcome barriers of lipid lowering therapy like clinical inertia, access to therapy, concerns over side effect, costs, etc. Try and help your patient wherever in whatever modality you can. Initiate lipid lowering therapy at appropriate intensity in high risk patients. Earlier the better, because longer you reduce it, better it is. Consider it combination therapy earlier in patients who do not achieve their goal or who are not likely to achieve goal. We roughly know which therapy will reduce how much. Statins will reduce by 50%, PCSK9 by 60%, uh, your bempedoic acid is going to reduce it by something like 20%, and ezetimibe something like 15%. So based on that, roughly you have an estimate how much particular therapy will reduce. If that is going to be enough based on patient's baseline LDL levels and its goals, fine. If not, then you might start upfront combination therapy. Challenges are in managing the patients with and at risk for ASCVD and even aortic stenosis. Nowadays, we believe that it is being contributed by both inflammation and dyslipidemia. Most patients at high or very high risk do not meet LDL thresholds. This is a stark reality. It is unfortunate, but majority of patients, they do not reach their thresholds because of the clinical inertia or fear of using high intensity statins or high intensity LDL reduction. Higher the risk, lower the percentage who achieve the goal. If your goal is 100, it's easier to achieve. But if your goal is 30, it's going to be extremely difficult to achieve, and you will really need to do an Herculean efforts to do that. Long-term adherence, persistence with statin therapy is even poorer. So even those factors need to be kept in mind and try and correct it. What are the concerns of extremely low LDL? Well, mutation in genes like PCSK9 absent or familial hypo-beta lipoproteinemia, familial A-beta lipoproteinemia have their LDLs in single digit or double digit, tens or twenties, right from birth. And they do not have any known adverse effect. In fact, they live quite long into 90s and hundreds. Statin associated muscle symptoms occur in almost 10% of the patients in unsupervised registries, but in a classical trials where every symptoms get evaluated properly, the incidence is not more than 5%. And if it is just myalgias which is tolerable, don't bother about it. If it is myositis, CPK elevation up to 3 times normal, don't bother about it. Above 3 times normal, maybe you can think of reducing statin or changing from water soluble to fat soluble statins or giving an alternate or even once a week therapy. Even that therapy is likely to have some benefit without muscle symptoms. Rhabdomyolysis is a very rare severe muscle related side effect which leads to an acute renal injury. Luckily, majority of them are reversible if they are identified early, but they are one in thousands. New onset diabetes again is a reality, but that happens largely in patients who are either pre-diabetic or who have a very high risk of developing diabetes, like people who have metabolic syndrome, pre-diabetes, family history of diabetes in both mother and father. This group of patients, even without statin, if you follow up for 5 or 10 years, large number of them are going to develop diabetes. The silver lining is that even if they develop diabetes, the ASCVD reduction, the fatal and non-fatal cardiovascular event reduction benefit is still there in this group of patients. So you need to treat these patients without being worried about new onset or diabetes or slight worsening of their glycemia. In that case, you can just intensify your anti-hyperglycemic therapy. That brings us to two major controversial aspects: neurocognitive dysfunction, which one slide I'm going to show, it's not a reality, and brain hemorrhage, it's a reality, but it's a very small concern. Bempedoic acid has a special side effect of tendon rupture, hyperuricemia, and gout. Very small liver or hematopoietic system concerns are there. Muscle symptoms are practically not there because bempedoic acid does not get metabolized there. Ezetimibe is a very, very safe drug, hardly any side effect except for unusual allergies. PCSK9 inhibitors and inclisiran, largely we see injection site reactions. Otherwise, no major organ side effects are found. And of course, newer agents, we will have to see what they have to offer. Neurocognitive decline, there is practically no consistent benefit of either neurocognitive decline or Alzheimer's disease. Meta-analysis do not confirm that. Statins and neurocognitive function, they have done a exhaustive analysis by all neurocognitive tests. Even in population studies, none has been found. In mechanistic study also, there is no plausibility that extremely low LDL would affect brain structure and function. So the current expert consensus says that you need not worry about neurocognitive dysfunction in ultra low LDLs, even in single digit. Brain hemorrhage, one large trial did show a slightly increased incidence of brain hemorrhage. Several meta-analyses showed also a slightly increased brain hemorrhage incidence, but the exact mechanism is not known. There is a theory that it increases the vascular fragility and changes in blood pressure dynamics. The final word is not out, but one thing is very clear, that risk is extremely small compared to the net clinical benefit you are going to get in. I would not really be worried about brain hemorrhage as a side effect in terms of achieving extremely low LDL. Now, what is the major barrier to dyslipidemia therapy? I think it is the phobia. Wikipedia shows phobia as an anxiety disorder defined by an irrational, unrealistic, and persistent excessive fear of an object or situation. Do we fit into this? I think large number of clinicians do. Those who are affected, they go to any lengths to justify their reaction. Do we do that? Brain hemorrhage, these, that, etc. Yes, we do. And it could be specific phobia. And this kind of phobia has been found not only in LDL reduction to extremely low levels, but even in heart failure therapies, particularly when MRAs are concerned, particularly when ARNI is concerned. Hypertension we are worried about, while 85 systolic pressure might be walking around. 5.5 potassium, we just start stopping MRAs. One should not be stopping, go by the guidelines. But these are the phobias: hyperkalemia, hypotension, extremely low LDL. And what is that? What is the uh, remedy to these phobias? Well, remedy to phobia is information, communication, and counseling, which is exactly what we are doing today. There is one Steve Nishan's WhatsApp forward which I am seeing. It's a kind of very smartly designed, that cholesterol has been removed as a causative factor. Very smartly designed, and it affects the lemon. One need to read that WhatsApp message, because I am sure every cardiologist, every physician is going to face that message from their patient, and counsel your patients about all potential side effects. Of course, in pregnancy, you need to be careful how and what to treat. So, coming to the last slide, friends. No cell in the body can live without cholesterol, because every cell needs a cell membrane, and cell membrane is made of cholesterol. But because it is so important, practically every cell in the body can synthesize its own cholesterol. So majority of lipidologists, when they meet, they say that you can live without LDL in the blood. Forget about single digit. Let it go down to zero. It doesn't matter. Ultra low LDLs have been found to be fairly safe and effective in extreme risk cases. Of course, everyone, you are not going to go to ultra low LDL levels, but they are in 5-10% of those extreme risk cases, it is found to be effective and reasonably safe, with a sizable clinical, meaningful net clinical benefit despite the host of uncommon side effects. Of course, we don't we should not be looking at LDL concentration. We should also be looking at LDL particle number and size and ApoB, which are the related parameters and far more specifically and causatively related to your atherosclerosis. But we lack a large amount of data, so as of now we don't focus much on that. And of course, best in lipidology is yet to come in decades to come. Thank you very much, friends, for patient listening. After this, we are going to run a small poll. uh, if you if your query cannot be answered in question and answer session, these are my contact details. Feel free to be in touch with me anytime for anything in cardiology. Over to you, Sharika. Please put the post session poll, please. So, friends, the poll question now is, going forward after this CME, do you intend to use high intensity statin, that is Rosuva 2040, Etora 4080, routinely in all diabetic patients above the age of 40, or all SES patients? Are you confident that you will be going for this? Answer is simple, yes or no. Take a few seconds and please vote. Wow. From 56%, the effect of lecture is 85% will go for it. Thank you very much for your patient listening. Over to you, Shaira, for
Much for that wonderful. It was very enlightening and hopefully very helpful for our doctors. We do have a lot of questions coming in from our doctors, and we will be getting into that, sir. So I'm going to be taking one of the earlier questions that we had. So it is from Dr. Ambaram. Does very low LDL reflect malignancy?
No, even malignancy, unfortunately, I think I skipped to put the malignancy as risk factor, but even that risk has been excluded. There is no increased risk of malignancy in ultra low LDL cholesterol levels. So one need not be worried about. One need not have any specific surveillance measure for any specific malignancy also. So that 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 concern is also has been largely answered so far.
So another question from Dr. Ambaram was, if you reduce LDL, how will you tackle high LPA?
If you
Even if you reduce LDL, how will you tackle high LPA?
All right. So I think even after tackling LDL, what he means that if your LDL does not respond, that's what I understand. Uh, so if you are not achieving your target, make sure that patient is following lifestyle, because all the trials done on dyslipidemia are on top of lifestyle. Lifestyle is extremely important, and lifestyle is one of the most difficult to maintain. So make sure that patient has done his lifestyle modification properly. Second one need to rule out is compliance and adherence, whether the patient is taking the recommended therapy or not. That is something which has to be, and once the compliance and this both have been taken into account, then you have to think of individual variability. Though we say that the high intensity statin are going to reduce your LDL by 50-55%, in every patient it does not happen. Like in FOURIER trial, where we have seen that PCSK9 inhibitors, which has 60% reduction in LDL on top of statin therapy, but in the graph we saw that some of the patients, their residual LDL was still 150, 160, 4 millimoles, and some of them they achieved below 10. So an individual patient is going to vary in response to LDL therapy. Rough responses are the ones based on which you start initial combination therapy, but after a couple of weeks, maybe 6 weeks or 8 weeks time, you check the LDL. If you have not achieved, you have to step up the therapy. So if the patient is on high intensity statin and he falls into one of the extreme risk category, then PCSK9 on inclisiran is the way to go, provided patient can afford and accept the injectable therapy. If the patient cannot afford or injectable therapy is not acceptable to him, then you can give a combination with ezetimibe, which has been approved so far. Bempedoic acid got approval for clinical use after the last guideline. Probably next guideline they are going to come, but you can also combine statin and bempedoic acid. And in bempedoic acid trial, there were n number of patients where statin and ezetimibe was already on board. So a triple combination also has been found to be fairly safe. So this triple combination therapy you can think of in a patient who fails to achieve the desired LDL goal. And in fact, I've been using in all my ACH patients triple combination therapy upfront. That's an off-label indication, and the tolerability wise, in few dozen patients where I have put, there is no major concern.
So taking the next question from Dr. Srivastava, which test is better, fasting lipid profile or random, and why?
Fasting lipid profile is only required if the patient has severe hypertriglyceridemia, like triglycerides above 400. Otherwise, majority of trials which were done were on non-fasting. Non-fasting would make sense because it's convenient. And nowadays, there are many point of care testing devices available in many hospitals or physicians' clinics, wherein the patient has come to take the opportunity to draw the sample and test the results, get the results immediately, and start therapy immediately. You order the test, and some number of patients are not going to get it done. So, and because majority of trials were done on non-fasting sample, and in fact, when triglyceride is concerned, both fasting and post-meal triglycerides both have their own clinical significance. But as a general rule, non-fasting sample is enough. So if the patient has gone to a pathology lab and by mistake he has taken a breakfast and gone, don't deny it because he is not fasting. Go ahead and get it done. Don't miss that opportunity. And all trial data, what we are seeing, they were all non-fasting samples.
Next question from Dr. Ambaram. Supplement with omega-3 fatty acid along with conventional treatment. There is summation in reducing the LDL. What are your comments?
Well, omega-3 fatty acids, whenever they were tried, they did not result in reduction in ASCVD. Nevertheless, they do have a role in patients with severe hypertriglyceridemia to reduce the risk of pancreatitis. But omega-3 is composed of EPA and DHA. Now, EPA is beneficial, DHA is not. So, if you have a pure EPA, then 1 to 4 gram of EPA was found to be reducing cardiovascular events in high risk patients by almost 25%. So, EPA is something which is to be preferred over the general omega-3 fatty acid. Now, that EPA is synthetic EPA. It is not something which is resourced, or it's not a non-vegetarian source, not a fish source. And EPA preserves the benefit minus the side effects. There are a lot of trial related queries which were there, but despite that, in patients where you are not able to achieve targets, or if the patient gets recurrent events, adding an EPA is not a bad idea.
So Dr. Kulkarni asks, will low LDL result in CAD in middle-age group of patients 35 to 45 years without any comorbidities? If yes, then which gender is more prone?
Sorry, can you repeat? This is a little bit long for me. Can you repeat?
Yes. Will low LDL result in CAD in middle-age group of patients 35 to 45 years without any comorbidities? If yes, then which gender is prone?
Which general?
Which gender is prone? Gender, sir.
All right.
So the question is
Okay,
also
I
displayed on the
got
screen.
the question here. Will low LDL result
Yeah.
in CAD in middle age group of patients 35 to 40 without any comorbidities? Well, if the patient has an extremely low LDL, if you mean, and if he doesn't have comorbidities, probably he is going to outlive any of us more than 100 years. So low LDL will not result. Intermediate or high or very high LDL can result in CAD between the age of 35 or 40. But if there is a low LDL, the chances are very, very low. But caveat should be kept in mind. Here we are talking about LDL concentration. If the patient has metabolic syndrome, if the patient has a fatty liver or a metabolic MASLD, what we call it nowadays, and we don't call it non-fatty, the non-alcoholic fatty liver disease. If that is there, then an LDL of apparently 70 might be equivalent to 140, because LDL particle number might be double. If the patient has a triglyceride of say 250, 300 in that patient, it is very high likely that his LDL particle is very small in size. So the same concentration of 70 is equivalent in rest to 140 because his particle numbers are almost double. So that patient can develop. But if he does not have comorbidities like obesity, metabolic syndrome, MASLD, then he is not predisposed to. The another factor which you need to keep in mind is lipoprotein A. Lipoprotein A is a variant of LDL where the apoprotein A has a similarity to very low LDL particle size, as well as similarity to uh, the coagulation factors. And hence both thrombotic risk goes up as well as atherosclerotic risk goes up. So if your LP little a is say 100, 150, then even in middle age they would be predisposed to. Otherwise, gender wise, I don't find any big difference.
Now, taking the next question from Dr. Anand, what should be the LDL goal in patients with overt hypothyroidism?
Well, overt hypothyroidism, again, you would be going by your risk calculators. Of course, you do expect that in overt hypothyroidism, if hypothyroidism related hypertriglyceridemia and high LDL is there, you start controlling thyroid, their baseline LDL levels will be achieved within a couple of months of achieving euthyroidism. At that point, you again reassess the patient for his risk stratification, because there is a reversible cause for hyperlipidemia in patients with hypothyroidism. So treat hypothyroidism, 2 to 3 months down the line, reassess. If you find that the LDLs are on a very high level, like 190, 200, something like that, or even with a modest say 130 to 160, but if you put the patient's other characteristics, like patient has diabetes, uh, non-alcoholic fatty liver disease, patient has got LP little a elevated, patient has got multiple premature coronary artery disease in the family. In that case, you might think of putting your LDL down early in the course, and as per the risk stratification, you take down your goal to 100, 70, 50, 40, as the case may be. But after controlling hypothyroidism, it might become easier to control that patient's LDL levels, or he may not need it at all if everything was hypothyroidism related.
Dr. Purohit asks, what is the minimum LDL-C level where there is no harm to the body?
In my clinical practice, I have at least uh, 50 to 20 patients who are in single digits, like 6, 8, 10. There are at least 40, 50 patients whose LDLs are below 25, and I have not seen any side effects. And as far as trials are concerned, they clearly showed that maybe very small increased risk of intracerebral hemorrhage, but otherwise no bodily harm comes if your LDL drops to below 30. So except for intracranial hemorrhage, no proven side effect has been shown simply because of the LDL reduction.
Next from Dr. Deora, should statins be avoided in an established case of hemorrhagic strokes or developed CAD? If so, what are the alternative options?
In patients with hemorrhagic stroke, if there is a significant cause found, say for example, patient had an intracerebral vascular malformation, or if the patient had hypertensive intracerebral bleed, I don't think there is a need to scale down your LDL therapy. The hemorrhagic risk of intracerebral hemorrhage has been found with an ultra low LDL levels, LDL levels which are going below 30s and 20s. Your routine LDL reduction, so if somebody had a left main coronary artery disease and angioplasty or bypass has been done, or somebody had a polyvascular involvement, I don't think that just because that patient developed intracerebral hemorrhage, that constitutes a contraindication. I would treat every patient with intracerebral hemorrhage. Only thing, in those patients, I will try and avoid going down to extreme low levels like 10s and 20s.
So, sir, since there are more questions coming in, is it okay if we take a few more?
Yeah, no problems.
Yeah. Next is from Dr. Surya Prakash. Our problem is triglyceride in India and not LDL. What are your comments?
Uh, well, I would agree and disagree both. Our problem is not purely triglycerides. We are a population who have a very high carb intake. We are a population who cherish being inactive. We as a population, we are not active and we're not very sports oriented. We love to watch cricket, but not everyone plays cricket. So yes, metabolic syndrome is on higher side, diabetes is on higher side. It occurs at an earlier age. High triglyceride is found in much more higher number of patients, but that is probably not the causative agent for ASCVD. And if you see the LDL target and non-HDL target. Now, what is non-HDL? Non-HDL is largely formed by non-LDL ApoB particles. ApoB is found in LDL, VLDL, and intermediate density lipoproteins and chylomicrons. Right? HDL is ApoA particle. ApoB is found in LDL, so that is LDL ApoB. VLDL divided by 5 is triglyceride. I mean, TG divided by 5 is your VLDL. So VLDL is nothing but your triglyceride. So your non-HDL target, if you want to achieve, you have to reduce your triglycerides. The problem is, even if your triglyceride is elevated, your primary goal is LDL. After achieving your LDL, your secondary goal is non-HDL, which contains VLDL, which in itself is a TG divided by 5. And despite all LDL reducing therapy which are proven, if it still remains on higher side, you can think of reducing triglycerides for ASCVD prevention, and for which icosapent ethyl or EPA is one of the best agent. Second best agent which we in India are fortunate is to have is saroglitazar, because saroglitazar is both PPR alpha and gamma agonist. These are the two molecules which reduce your triglycerides very significantly, effectively, without causing any side effects. But primarily, if somebody comes to me with high triglyceride of 250, I'll just do his ASCVD risk estimation and I'll just treat him to down to lowest levels.
Next question is from Dr. Rajat. Can we use Rosava and Atarva simultaneously?
No. Rosua and Atarva we are not going to use simultaneously. Rosuvastatin I think is water soluble. Atorvastatin is fat soluble. They have a little different hepatic enzymes taking care of their metabolism. To me, both are more or less equipotent. Rosuvastatin is shade more potent. So if somebody use on atorvastatin, high intensity is not achieving targets when other therapies were not available, I was giving them rosuvastatin. And another benefit is that if somebody gets a muscle associated side effect with Rosuva, I change over to Atarva. And on Atarva, if they get, I change over to Rosuva. If it is mild to moderate side effect, you have a time to experiment with this because they have a different hepatic metabolism and different people might respond a little differently. By and large, they would respond similarly, but there might be a small difference. Before abandoning statin for mild to moderate myalgia, I would give it a try with a different molecule, but definitely not combination together.
Next from Dr. Sharma. Sir, the ASCVD score does not take in account LDL level. Doesn't this create a lacune in the score?
ASCVD risk calculator, if you go into the pooled cohort equation, it does take into account, I think, total cholesterol. So indirectly, LDL has been already factored in. I don't think there is any risk calculator which does not take into account either total cholesterol or LDL cholesterol or total cholesterol LDL cholesterol ratio or LDL HDL ratio. So it does take into factor the LDL directly or indirectly.
So, doctors, in the interest of time, taking the last two questions. However, all the questions that remain unanswered, I will find a way to get them answered from our expert. So the next question is from Dr. Varalakshmi. With the statins, patients' LDL cholesterol levels are decreasing, but along with that, HDL is also decreasing. How to handle this state?
HDL is a very mysterious and enigmatic molecule, I would say. It's very difficult to define. The trials have not focused on post-therapy HDL reduction. So, in my opinion, if you are going to go for very aggressive LDL targets, you should not be really worried about HDLs dropping. And anyway, we do not have any therapy to increase HDL, which translates into ASCVD reduction. Increased HDL was found to be effective with certain group of molecules, but they were found to increase the cardiovascular risk rather than decreasing it. And HDL has multiple variants, multiple sizes, multiple physiologic roles. So the reverse cholesterol transport hypothesis has still not been proven. So if your total cholesterol comes down, your proportionate HDL reduction is not, it's not disproportionately reducing HDL. So I would not be really worried about in those group of patients HDL dropping down. I would not scale down the therapy. So far as my LDL drops, I am happy with it.
So taking the last question for tonight. This is from Dr. Acharya. What to do when the LDL is 50 but triglycerides remain 250 with adding seraglutazar or fenofibrates?
What to do if LDL target is achieved and TG remains 250 despite using fenofibrate? Okay, so if on fenofibrate, if it is not getting achieved, you have two options, rather three options. First and foremost is to make sure that patient has reduced his carbohydrate intake, reduced his fat intake. Carbohydrate and fats, both of them, they give rise to high triglyceride. Alcohol is another reason for persistently high triglycerides. If some patients is not convinced about it, ask him to take triglyceride today, take 2 to 3 packs of alcohol tonight, and check his triglycerides again tomorrow morning. You will find that. So reversible factors like diet, exercise, body weight, alcohol intake, hypothyroidism, take care of all those. After those are taken care of and you are giving fenofibrate in adequate dose, still you are not getting a TG reduction, and you need to reduce his non-HDL target. Primarily, we don't target triglycerides below 400. Above 400, we treat to prevent pancreatitis. But if your non-HDL target is not achieved, your LDL therapy you have intensified to the maximum way possible, then along with fibrate, you can combine icosapent ethyl, which is EPA, up to 4 grams per day you can combine, or you stop fenofibrate and give saroglitazar, because saroglitazar is PPAR alpha gamma agonist and fenofibrate is PPAR alpha agonist, so both you cannot combine together. So replace fenofibrate with saroglitazar. I have found much better effect with saroglitazar, even in non-diabetic patients. Non-diabetic patients, it would be an off-label indication. It's approved for diabetic patients with hypertriglyceridemia, but not the other patients. Then you can use saroglitazar, and EPA again can be combined with saroglitazar. So these are a few of the options if you really need to go after triglyceride. Otherwise, if you have achieved your LDL target, TG of 250, you can simply ignore.
So, thank you, sir, for taking in the questions from our doctors. And doctors, we've tried to get most of them answered. Whatever is remaining, we will get it answered from the expert and post it on the discussion page once the session replay is being uploaded. Thank you once again, sir, for taking in the questions from our doctors. With this, I would also like to mention that there are a lot of positive feedbacks for this session. Our doctors seem to have really loved it. Thank you once again for this wonderful session, sir.
Thank you very much. Have a good night, everyone. Bye-bye.